Thanks for Barbara. I hope to see her here because we are working again together in the, as associate in the guidelines panels of neurourology of the EAU. So I miss and I just want to come back to some points that Barbara has already stressed about the algorithm of initial evaluation for mixed urinary incontinence. And if we see the algorithm recommended by the international guidelines, the algorithm is the same for all the types of urinary incontinence, as you can see. And it's mainly based on subjective tools like questionnaires, as Barbara told before, and some objective tools like diary, post-voiding residual, and urine analysis, and physical examination and the clinical history, of course. But what we must understand if there are some aspects, peculiar points that we can take into consideration to discriminate subtype of mixed urinary incontinence with these tools. And so if we take into consideration the clinical history, we know that taking alone its sensitivity for stress urinary incontinence, and it's specific for urge urinary incontinence, but not for mixed urinary incontinence. What does it mean? It means that all the baseline characteristics, demographic or comorbidities are mainly correlated to one type of urinary incontinence between stress urinary incontinence or urgency urinary incontinence, or both of them. And indirectly, it's correlated to mixed urinary incontinence, of course. But the only factor which seems that it's directly correlated to mixed urinary incontinence in clinical history is the previous surgery of urinary incontinence. It means that it's not performing at the initial of the evaluation, but later. And also obesity, we know that it's a significant correlated in stress urinary incontinence and urgency urinary incontinence for the diagnosis of mixed urinary incontinence. It's not correlated with the presence of mixed urinary incontinence, but it's correlated with the risk of no remission of mixed urinary incontinence after treatment. And regarding questionnaires for screening mixed urinary incontinence among the different types of incontinence, this questionnaire, which was designed for this purpose, the 3 incontinence questionnaire, it's a good predictor for stress urinary incontinence, but it's not a good performed for, it's underestimate urgency incontinence and mixed urinary incontinence. About the symptomatic questionnaires and the assessment of quality of life, I agree with Barbara that we have many questionnaires, validated tools that we can use to assess urgency and stress urinary incontinence at the same time. But if we see all these questionnaires, which include domain for stress urinary incontinence and urgency incontinence, there are no specific subdomains which can discriminate subtype of mixed urinary incontinence. But we know that the impact on QOL in these patients with mixed urinary incontinence, it's even worse, as Barbara told before. And we know that these patients complained more incontinence, even stress or urge type, rather than pure stress incontinence women. And the same for the effect of sexual symptoms, as Barbara told before. But there is, in this study, we also saw that the impact on sexual dysfunction, it seems that in mixed urinary incontinence, there is more orgasmic disorder than in stress urinary incontinence, and more libido loss than in urgency incontinence. Regarding the diary, which was shown before, I just want to analyze with you the column that usually the patient must fill. And if you see well, there is no information for stress urinary incontinence, and so also for mixed urinary incontinence. Urine analysis, well, is it useful? Perhaps it's more useful to assess the microbiome inside the urine. There is this interesting paper analyzing the quality of bacteria inside the urine, and in this systematic review was documented a loss of lactobacillus in mixed urinary incontinence compared to other types of urinary incontinence. And this is also confirmed by this multi-center interventional study. They treated patients with lactobacillus before sling, and they saw that there was it's maybe too loud. And they saw that there was a significantly improvement of subjective response after lactobacillin treatment before sling in this patient compared to patients who didn't have this treatment. But coming back to the main question, so urodynamics, when we should perform it, if we see the guidelines, of course, we have to do it before complicated type of urinary incontinence and also in neurological patients. But the main question is another one. Do we need to perform urodynamics always before surgery? And if we see this systematic review published 10 years ago, it seems that in patients with predominant stress urinary incontinence, we could avoid urodynamics because results in subjective perception after TOT or TVT was the same for this meta-analysis, with or without the confirmation of urodynamics. And this theory is also confirmed by some urodynamic tests like this. In these studies, they saw that leakage during coughing with the concomitantly onset of DO, detrusor overactivity, was very poor. So only about 5% of women leak during cough because detrusor overactivity. But I agree that we need to consider urodynamic also for another reason, not only for the indication, but also to give to the patient a proper counseling before surgery. Why? This is a recent study that it's documented that in patients with predominant stress incontinence undergoing to mid-urethral sling, having detus or overactivity, a urodynamic, have a worse response, also in objective and subjective outcomes. About 50%, 55% of these patients respond, compared to an 85%, 85% of patients with a predominant stress urinary incontinence, but without NDO, without DO. The same, again, the perception of satisfaction is low in these patients also in the long term. This is a study after 6 years follow-up, and they saw that, the authors saw that in patients with stress incontinence and DO, detrus or overactivity, they were less extremely satisfied at 6 years follow-up than the sample, the group without DO. And we also must be careful, because those patients who are at risk of failure, they are the same patients who usually don't respond to antimuscarinic before surgery. This is a study in which they found that patients with OAB, overactive bladder medications before surgery was the major risk for failure at 1 year of mid-urethral sling. So to conclude, we must consider that the group of patients with predominant stress urinary incontinence, in the 50% of cases, they can have detrus overactivity at urodynamic. This is a study that was discussed in the last International Continence Society in Las Vegas online, unfortunately. But I agree with you that sometimes urodynamic is not helpful to detect dysfunction in several cases. In about 20% of cases, there is no dysfunction detected at urodynamic. So perhaps we need more other kind of tests to overwhelm this gap of urodynamic. One could be the use of ambulatory urodynamic, but the problem now is the invasivity of these tests. So we need to find new non-invasive device. And other research should be performed in order to assess and standardize other tools, like the assessment of the bladder wall thickness by ultrasound or magnetic resonance to determine if there are some predictor factor for OAB, and the same for markers. Thank you.